Okay, so hello everyone, this is Daniel Shahid. I'm a fourth year medical student and I'm the co-founder of USMLE Pakistan. And this is our question solving series, and this is continuous from the third episode. Okay, so yeah, so here we go, starting with our first question. So by this time, I'm sure that you might know that what was the sequence of and what's the fashion of solving the question. So we're gonna read the last line, and then you're gonna skim the options, and then I'll give you time, or you can pause the video for 1 minute to read the stem, make the diagnosis, and come back with the answer. Okay. So a mutation affecting which of the following is most likely to cause patient symptoms? Bada, bada, bada. So now skim the options. Cardiac cells had a skeleton protein. Cardiac cells sarcomere protein, migration in this and that. Casimani circular boom and Mac membrane message channel protein. Okay. So I got to know that question is asking about some sort of mutation in the cell and in the different part of cells. Of course, mutation are in the different part of cells. Anyways. Okay. So yeah. That's really awesome. Now I give you 10 seconds. Oh, sorry. You can pause the video and you can read out the stuff. Okay. So 21-year-old man is brought to the emergency department after a sudden episode of syncope. Mm-hmm. He reports no prior history of lightheadedness, chest pain, palpitation, or seizure-like activity. The syncopal event occurred without any identifiable trigger and resolved spontaneously within minutes. Mm, concerning, red flags, red flags. Okay. He has no past medical history and takes no medication. His family history is non-contributory and ECD in emergency department shows prolonged QT interval. Okay. So, I have highlighted the red flags with the green color. Very interesting. Anyways, so yeah, what are you witnessing in this scenario that the patient is having unprovoked syncope? Okay, as it is mentioned in the question that there is no identifiable trigger, so this is an unprovoked syncope. Now, let me tell you, there are different reasons for syncope, but one of the main reasons of syncope, and one of the most prevailing reasons of the syncope, common reason you can say, prevailing would not be a good word for it. So, the common reason of the syncope is tachycardia. What happens in tachycardia that your heart is contracting very fast, so your heart is not getting enough relaxation. If there is no enough relaxation, there will be no enough blood. Okay, and there is no enough blood. Uh, so there will be no enough ejection of blood from the heart, and this leads to low cardiac output, ultimately low cerebral perfusion, and this leads to so you know that tachycardia leads to okay. Now you can see that on the ECG, it is given that on the ECG, the patient is having prolonged QT interval. So you all know that prolonged QT interval leads to a form of tachycardia, which is called as diastolic spontaneous, and it is very lethal. It causes a death, sudden cardiac death in the patients. So it is one of the lethal tachycardia. So the patient is having prolonged QT interval on the ECG. Now, before really explaining or dipping into that, I want to explain you certain things regarding the ECGs and the cardiac action potential. And now let's continue with that. So you can see that I have mentioned or I'm showing you that different phases of cardiac action potential: phase 0, phase 1, phase 2, phase 3, 4. Now, every you can not like each, but yeah, you can say that each phase of cardiac action potential correspond to the ECG, and it is really super high you to know because if you know that which phase in it is is involved. If you really know that which phase affects which part of ECG, then you can suggest that which electrolyte abnormality could lead to the changes in the ECG. Okay. So first of all, I'm gonna explain you this in a very less time, because again, this is not a complete factor. This is a tutorial. So, and we're gonna discuss the principle here. So phase zero of the action potential is rapid sodium influx. This correlates with QRS complex on ECG, representing ventricular depolarization. Then comes phase one and phase two of the heart. Phase one is actually the initial repolarization in which the voltage sodium channel closes and the voltage potassium channel opens. There is a transient potassium outflow. Then comes phase two, which is a plateau phase, and we all know what is plateau phase. It's static phase on a graph, a balanced phase on a graph. So it happens due to the balance of calcium influx, means positive ion coming in, and potassium outflux, positive ion coming going out. So positive is leaving, positive is entering, so that leads to a balance. Okay, so the phase one and phase two of the cardiac action potential represent the ST segment of the ECG. Okay, now let's talk about the phase three. In phase three, what happens that the voltage gated calcium channel closed, and now the voltage gated potassium channels were open, and now the continuous now there is a continuous release of potassium out of the cell. So actually, in phase three, it's a big liberalization phase. As compared to phase one, it's a big liberalization phase in which potassium leaves the cells, and this aligned with the T wave on the ECG. Phase four is not associated with any significant part of ECG. So let's end final discussion from phase zero to phase three. Okay. So finally, what happens that now there's something called QD interval, and I'm gonna relate the cardiac action potential from QD interval. Okay, so QD interval is actually it starts from the start of phase zero, the start phase zero of the cardiac action potential, to the end of phase three. So it means that QD interval is covering with entire ventricular electrical activity, means depolarization, plateau, and repolarization. So now how to prolong QT interval? So if you stop the efflux, or if you block the efflux of potassium channels from your cardiac membrane or cardiac cells, so it would lead to prolonged phase 3 or prolonged repolarization. Ultimately, the effective refractory period will enlarge or will increase. You can see the effective refractory period is from phase 0 to phase 3, and you know ERP, which is effective refractory period, it correlates with QT interval. So what happens that if ERP is enlarged or increased, then QT interval will also increase, and this correlates. This is how the blockage of potassium channel leads to increase QT interval. Okay, so now let's get back to our question. So now you can see that uh, in this scenario, the answer is clear and obvious that a mutation in the membrane potassium channel proteins might lead to the prolonged QT interval, and the prolonged QT interval leads to pulsars, and that leads to the unprovoked syncope. Now, what's the clinical pearl here? That the patient was having no program of ECG. Okay, the patient was having no program of ECG, and he's a young patient, and having normal structure heart and unexplained syncope. You have to always think of transcatheteropathy. This is a high yield and very important for your step on exam, that you must know. It's a clinical pearl that if a patient is a young, and he's having unexplained syncope, and unexplained syncope means the syncope has no prolong. And if you look at the structure of the structure of heart is normal and everything is normal, besides the channels of the heart that precipitates the 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 tachycardia or certain type of parallel arrhythmia that lead to the syncope. Okay, so sudden unprovoked syncope, easily showing prolonged QT interval, that was class type of congenital long QT syndrome. Okay, so long QT syndrome, let me go into the detail of it. So that long QT syndrome is mostly caused by mutation in membrane uh, potassium channel proteins. And these channels like KCN2 1, KCN2, and KCNS2, if I'm not wrong, are crucial for peaceful utilization of the cardiac action potential, and impaired potassium outflow leads to prolonged utilization, longer QT, and pierced result that leads to syncope, sudden cardiac death. So that concludes our first question. Now let's go to our second. Okay. So, uh, read our last line, my friends. Which is the following best describe the primary pathophysiological mechanism responsible for this patient. Oh my. Okay, so let me tell you how to solve certain such type of question. Okay, in the S7 exam, you might encounter the question with figures. So how I used to deal with such type of person, and I still deal such type of person in step two exam, in the preparation of step two exam, that I first of all look at the picture. I first of all look at the labs, because looking at the picture or interpreting the labs give me an idea that what is actually happening in the question. What's going on? Picture give you 90% of idea, and you just need to read out the system and give the answer. If you identify a picture and if you interpret the labs correctly. So, first of all, let's look at this picture. Okay, so this picture is giving an idea that there is the thinning of ventricles. And the ventricles are thinning of the wall of ventricles, of course. And the ventricular wall is enlarged as well. Okay, so you know very well that normally the wall of the heart, I'm not talking about wall, I'm talking about wall, WALL. So normally you know that the wall of heart is not that much thin. It's got something first. It is not that much thin. But in this case, you see that the wall of the heart is thin, and the chamber of the heart is too much dilated. Of course, it's a concerning feature of D. I'm not telling you. So you have to read that last line, and now let's get to our options for this decreased ventricular contraction force. Okay, first of all, what is question asking? The question is asking about a primary physiologic pathophysiological mechanism responsible for this patient's symptoms. Okay, so decreased ventricular contraction force. Da 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 da. Boom 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 boom. Okay, now let's get back to our explanation. I'm sorry. Let's get back to our question stem. Okay. So you can see that this is a 14-year-old man that is present to the emergency department with fatigue. Okay. And worsening shortness of breath on exertion. For the past 2 weeks, his symptoms have progressed to the point where he's unable to walk across his living room without becoming breathless. Despite intensive medical management during the hospital stay, he dies suddenly. Autopsy of the horizon. Why I have highlighted certain things with green. I intentionally highlighted them to tell you that in your 7 exams, certain questions have a non-specific findings. You can see that worsening shortness of breath on exertion and all these symptoms can also be seen in angina. They can see in pulmonary edema. They can be witnessed in your dilated cardiomyopathy as well. So they are very non-specific symptoms. When the symptoms are non-specific, the question might give you certain picture or lab that would be enough to answer the question correctly. Okay, so the autopsy confirms that it's dilated heart on autopsy. Oh, that's the heart is dilated, and the dilated and it is one of the most common type of cardiomyopathy, the dilated cardiomyopathy, the DCM. And it can be idiopathic, it can be familial, it can be genetic, or it can be secondary to alcohol abuse, or I guess myocarditis, chemotherapy, like Wisby's, doxorubicin, and peripartum cardiomyopathy, and hemochromatosis. Okay, so these all leads to DCM. Anyways, so what actually happens in DCM that DCM causes eccentric hypertrophy. In eccentric hypertrophy, what happens that the cardiomyocyte lines side by side to each other, and that leads to thin ventricle. In contrast to concentric hypertrophy, cardiomyocyte lie over the top of each other, and that leads to thick ventricle. So the DCM causes eccentric hypertrophy, and in this ventricle dilate and ventricle thin out. The heart loses its ability to contract effectively. Of course, you can think that if anything is dilated too much, so it can't contract effectively. Okay, so that leads to systolic dysfunction. Remember for the rest of your life that DCM causes systolic dysfunction and HCM causes uh, diastolic dysfunction. Again, why systolic dysfunction in DCM? Because heart is too much compliant, right? And it's a loose bag now, just a loose bag who got nothing, not who cannot generate enough force to check out the blood. So that leads to reduced ejection fraction, and the reduced ejection fraction there is back off the blood into the lungs, and that leads to pulmonary edema, of course, and that leads to dyspnea, fatigue, and congestive heart failure symptom. So the final event, remember, whenever the heart is dilated, the final event is arrhythmia or pump failure, and again that leads to sudden death. So we have faced two lethal event so far. The first one is this, the tachycardia one, and the second one is this, the DCM one. So what should be the answer, my friends? Of course, the answer should be A. Because as I have explained you that decreased ventricular contraction force, the heart is not able enough to eject out the blood because it's a loose bag now. B, dynamic left ventricular artery obstruction. That's HCM, not DCM. And C, impaired ventricular filling. That's a diastolic dysfunction, which is seen in restrictive or hypertrophic cardiomyopathy. And this D, impaired left ventricular, the D one, the D, increased pulmonary vascular resistance. So it is seen in pulmonary hypertension that might lead to heart failure, but that's not the primary concern in DCM. So of course, he's not an answer. Poor wall compliance. It leads, as I've told you, that in DCM there is increased ventricular wall compliance. So of course, it's not the answer. And poor ventricular wall compliance seen in. You guys have to answer this in the comments, of course. I'll explain you again. Uh, so that's it for this question. Okay. So now, the second one. Okay. Blah 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 blah. It's a bit tricky one, a bit tricky one, not at that field. It's 2 degree question, you can say. Okay, so which of the following medication was most likely administered? You can go through the options. Hydrazine, levodopa, latrolol, antidepressant, phentolamine. You know that I used to read out the options, especially for pharma. So in my mind, I used to worry if I don't know the mechanism of any single drug. Okay, so those were 7 days of the distressing ones, but anyways. So yeah, okay, just came the options. Yeah, just came the options. Now you got to go over this thing. But again, if there is anything given in tabular form in the question, just skim that first. Because again, it's going to explain you a lot of things. Trust me, a lot of things. So I give you even pause the video and read out the explanation, the stem. Okay. Yeah. So, a 72-year-old man presents to the emergency department with intermittent chest pain that has been waxing and waning over the past several hours. He was experiencing similar discomfort for 5 to 10 minutes while walking briskly up the stairs. His medical history include hypertension, hyperlipidemia. Oh my god, he has a lot of things going on. But he has been non-adherent to medication follow-ups. I seem like not a good patient. Won't die early. He has 35 pack area the smoking history, not good. Okay, so on examination, you see that blood pressure is elevated. 211 by 105 is something really concerning, guys. Pulse is 88 per minute regular. Fine. So chest, no murmurs, good to go. Lungs clear, good to go. ECG sinus rhythm with not specific FT segment changes. Okay. Okay. Sinus rhythm. At least he got sinus rhythm. Anyways, so after IV administration of the medication, the following hemodynamic effects were observed. So the stroke volume unchanged, systemic vascular resistance decreased, and heart rate decreased. So now you have to think of a drug that causes decreased heart rate as well as um, decrease systemic vascular resistance. So the drug should lower down the heart rate and the drug should vasodilate. So I guess we should go one by one to each drug now. First of all, let's talk about hydrology. So hydrology is a pure arterial vasodilator and that leads to decreased systemic vascular resistance that would cause reflex tachycardia but not bradycardia. So of course, it's not the answer. Okay. So let's talk about, I'm skipping the B right now, and let's talk about metoprolol. Metoprolol is a selective beta-1 blocker, and you know that beta-1 receptors are found on heart only. They are not found in the vessels, on the blood vessels. On the blood vessels, we have alpha and beta-2, alpha-1 and beta-2. So, metoprolol is selective beta-1 blocker. Okay, let's call it decreased heart rate. That might be the right answer. But now I think that it don't it doesn't have any major vasodilatory effect. So systemic vascular resistance would be unchanged. So the metoprolol is not the answer. Sadly. Okay. Let's talk about nitroprusside. It's a potent arterial plus venous venous vasodilator, or you can say venodilator. Okay, that's interesting. So, what happens when the arteries vasodilate? Systemic vascular resistance will decrease. Okay, I think that's the answer. But when the systemic vascular resistance decrease, there is reflex tachycardia. So, D is not the answer. Oh my god. Okay. Phentolamine might be. So phentolamine is a non-selective alpha blocker. Oh my god, I think I got the right answer. And it vasodilates, decreases systemic vascular resistance. But again, when the systemic vascular resistance is decreased, it leads to reflex tachycardia. So phentolamine is not the answer. Now I'm left with only levetiracetam. Okay, so letrozole. Of course, letrozole is the correct answer because letrozole is alpha one blocker. S- Well, at Abdul, you are here that on the blood vessels, one of the major receptors in the sympathetic and parasympathetic nervous system we find are alpha 1 and beta 2. Beta 1, beta 2 is vasodilatory. Beta 2, yeah. And alpha 1 is vasoconstrictive. So if you block the alpha 1 receptor, which is the function of levodopa, so it would lead to decrease uh, systemic vascular resistance and vasodilation, of course. Okay, so of course, oh, so just like hydrazine, just like phentolamine, just like nitroprusside, uh, it would also lead to reflex tachycardia, right? No. Lebrikizumab is not only alpha 1 blocker, it is also beta 1 blocker. So even if there is an attempt by our body, by our CNS to increase the heart rate in the form of reflex tachycardia, lebrikizumab got beta 1 antagonist effects, and it would lead to decreased uh, heart rate as well. So the correct answer is lebrikizumab. And the clinical part here, lebertolol is go-to IV drug in hypertensive emergencies. I remember in Sketchy there was a pump and that was demonstrating a hypertensive emergency. Lebertolol is especially when you need to decrease heart rate and BP control, lebertolol is go-to IV drug. So think of it as a brake plus a widen road drug that slows down the heart while lowering the resistance. Okay. So the next question, yeah, I have highlighted 13 things for you here to to focus. But I think I have explained it. So let's move toward the next one. Okay, so yeah, which age-related vascular change will most likely explain this patient's isosystolic hypertension? So you must know what is isolated systolic hypertension. It's like having only elevated systolic blood pressure, but the diastolic blood pressure (DVB) is normal or low normal. So okay. So the patient is aged, and there is certain you can skip the options now. So the patient is aged, and he's having certain age-related vascular changes, and that is leading to atherosclerotic hypertension. Let me see. Decrease diameter of aortic lumen, decrease stroke volume, increase arterial collagen deposition, increase renal arterial resistance, increase lymphatic tone, blah blah blah. Okay, now let's go back to our stones. Okay, so a 78-year-old man is evaluated for persistent headaches that improve with over-the-counter acetaminophen. You know that taking as too much acetaminophen also leads to headaches. Anyways, that's not about our discussion. He takes no prescribed medication and has never smoked. On today's exam, his blood pressure is 180/70, and his the pulse is 75 per minute, and BPM and regular. That's good. His previous visit shows elevated BP of 176/85. So it means that he's having chronically elevated blood pressures. That's not good. Physical examination is normal except for an S4 gallop. Okay. A CT scan of the head is unremarkable. Let me tell you about something regarding S4 and S3. You must know that four S3 is sorry, S4 is normal in elderly, right? Starting in sometime S4 is normal, but sometimes it can be pathologic as well. So this is just to share a bit detail with you. It got nothing to do with this question. Anyways, so yeah. So this patient is having either systolic hypertension. You can see as systolic BP is high, but the diastolic blood pressure is normal or low normal, and that's and he's elderly patient, and the it is accompanied by asphodelap. So it is accompanied by asphodelap, and so the most common cause of uh, isolated systolic hypertension in elderly is decreased aortic compliance. Now, let me tell you, what is actually systolic, what does actually systolic blood pressure means, or which parameter of our artery determines systolic and which parameter of our artery determines diastolic. Remember, the compliance of the arteries or aorta are the determinants of systolic blood pressure. If there are any changes in the compliance of artery, so that leads to changes in systolic blood pressure. On the other hand, the diastolic blood pressure is determined by the tonicity of your vessels. Okay? So that's the basic principle of blood pressure. I guess you should know this, and if you don't know, you should note it down and remember it for the rest of your life. It's gonna make your life easier to know what's actually going on in the patient. Okay. So the common cause of isolated systolic, of course, first of all, if the patient is having isolated systolic hypertension, now, what from what I have told you, you will think of that. Okay, the compliance of artery is decreased. Okay, that's cool. So in elderly patients, how can you what can you expect, and what you think, what do you think of that? What might cause the increase compliance, sorry, the decrease or the compliance, the decrease compliance of artery, which thing, which pathology can cause the decrease or the compliance? So in elderly, we know very well, in elderly there is increased collagen and decreased elastin. Okay, so this is what leads to uh poor aortic compliance, and that leads to elevated systolic blood pressure. Okay, that leads to elevated systolic blood pressure. But in such scenarios, the tonicity of the artery doesn't change. You know, if the tonicity is decreased, so it means DVT will decrease. If the tonicity is increased, it means that the DVT will increase. But in this case, the tonicity doesn't change. There is no change there. There are no changes to the tonicity of the artery. So the diastolic blood pressure remains same. So increased collagen, decreased elastin leads to decreased aortic compliance, and that leads to arteriosclerosis, not atherosclerosis. It's totally a different thing, and arteriosclerosis is a different thing. Okay. So this leads to less distensible arteries, and that leads to high systolic blood pressure when the heart contracts. Okay, so why? So of course, from what I have explained to you, the answer is of course C, the increased arterial collagen deposition. Okay, so why A is not correct? Because decreased diameter of the aortic lumen. And that's a normal. That's not a normal aging change, and it occurs with in atherosclerosis, not aortic or aortic stenosis. The decreased diameter of aortic lumen occurs in atherosclerosis or aortic stenosis, not in our case. Okay, so and yes, if the diameter of the aorta is decreased, so that leads to increased systolic as well as diastolic blood pressure, because you know that you have to breathe a lumen too. Okay. Next thing, decrease stroke volume. B. My friend, it would lower systolic blood pressure, not increase it. So it doesn't fit this case. Totally a vague option. Increase arterial resistance. That might be interesting one, but and it's seen in renal artery stenosis. It's first of all, it's not a normal aging phenomena, and that leads to both rise in both SBP and DVP. Finally, E, increase in sympathetic tone. That could raise the blood pressure short term, but not chronic. Okay, not chronic. Uh, E option is a bit concerning one, you know, because since increased sympathetic tone might lead to isolated systolic hypertension. But again, it would lead to a short-term ISH, not a chronic ISH. So it's not, and of course, it's not the key driver in age-related cardiac hypertension. So the C1 is the correct. Okay, so I guess yeah, I got one more question to for you here, and but I want to share a clinical part with you from the previous question. So increase systolic hypertension in older adults. It means that there is loss of artery elasticity, which is due to increased collagen and decreased elastin, and manage this with diuretics or CCD, especially elderly. Okay, so yeah, last one. Okay, so first of all, look at the autopsy because I have given you a detail of autopsy. So this question they are taken from authentic USMLE preparation resources. So they had designed the question in such a way. So yeah. So autopsy shows that her left atrium shows, autopsy of her left atrium shows that there is decreased fibrous thickening. Okay, lot of changes in her autopsy, lot of changes. Okay, so the question is asking about what is most likely cause of her valvular abnormality. So it means the question is demanding and question is to it. And the STEM would give you information regarding certain valvular abnormality. And the question is also asking about certain valvular abnormality. Okay, so congenital heart disease, imperative valvulus, calcinosis, imperative ventriculitis, blah 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 blah. About tons of options. So now let's get back to our STEM and read other stuff. So a 42-year-old woman is brought to the hospital with right-sided weakness and difficulty speaking. Of course, it's a stroke. She not good. She has long-standing diastolic murmur but has poor medical follow-up. She does not use tobacco, alcohol, or drugs. CT scan on the head reveals a large ischemic stroke in the left metacerebral artery tertiary. Uh, I'm so sorry for her. I'm so sorry, really. Despite tears, she dies 2 days later due to worsening neurologic status. So her autopsy details are given. So now this thing of it. Okay. How do you think of it? First of all, since the person is asked about valvular abnormality, so excuse me. So think of the condition that leads to abnormal valve. Okay, now you know that the stem is let me forward it. So now you know that the stem is focusing. The question is focusing on certain valvular pathology. So now focus on the murmur. A murmur will tell you a lot. So the patient is having diastolic murmur. The diastolic murmur will make you think of mitral stenosis. So commissural fissure. So what happens in mitral stenosis? You know very well that there are commissural fusion and thickened leaflets, narrowed mitral orifice. So that's a pathognomonic for mitral stenosis, and that's also a pathognomonic for your chronic rheumatic disease as well. But uh, now you might be thinking that how this all leads to stroke. So first of all, let me tell you that what happens, what is actually going on in this case. What is actually going on in this case? That your patient. First of all, you look at the autopsy. The again, first of all, follow the trend of the question. The trend of the question is making you think about certain pathology involved. Okay, now just think about the murmur. The murmur is a diastolic murmur, and that's classic for your mitral stenosis. Mitral stenosis murmur is Is a diastolic murmur. Okay. Now the autopsy is showing that the patient is having narrow mitral stenosis, which further confirms mitral stenosis. And she's having coronary fusion and distortion of the mitral wall deflects, diffuse fibrous thickening. This is all classic for rheumatic heart disease. Rheumatic heart disease affect mitral wall mostly, then aortic valve, and then tricuspid valve. So mitral valve is a favorite site for rheumatic disease to affect. Anyways, now what's why it leads to stroke? So this question is not only for the explanation of rheumatic fever. It's also an explanation for certain principles regarding the changes in your heart. First of all, that what happens that whenever there is mitral stenosis, it means that the blood is not ejecting out from the left atrium. If the blood is not being perfectly or the blood is not being correctly ejected out from the left atrium, so the blood started to building up, and that leads to dilation of the left atrium. Now, what's the basic principle of cardiovascular? That whenever anything leads to dilated left atrium or right atrium or any atrium, we got two atrium of course. So whenever anything is dilated atrium, that precipitates atrial fibrillation. That's cool. Now what happens? Now it's not cool for the patient. It's cool for us to understand so that we can treat the patient who's not feeling much cool. Okay. So what actually happens that in atrial fibrillation, the blood is stagnant, right? In atrial fibrillation, the blood is stagnant. If it is in right, if the atrial fibrillation is in the left atrium, blood is stagnant in the left atrium. If the atrial fibrillation is in the right atrium, that is stagnant in the right atrium. But anywhere, the major thing is that the blood is stagnant. When the blood is stagnant, it has high propensity to make the clots, right? Whenever blood is stagnant, it has high propensity to form clots. Okay. Now what happens that these clots would travel somehow, eventually they will travel down to the mitral wall and into the left ventricle. And from the left ventricle, they will travel into the systemic circulation, right? Remember, when